Hi, this is Eric Wilkie. I was going to show you how you can use some Dragon auto text templates in Cerner to do a very big or complex chart that will match or meet our medical decision making criteria that are coming up for 2023. So I'm going to do a complicated chart. Again, I know that what you're seeing is not Cerner, but this will basically mirror the function of the Dragon Medical One templates. So I'm using my cell phone, my my iPhone for the power mic. So let's see how long this takes me. Chest pain. The patient is a 66-year-old male presenting with left-sided, non-radiating chest pain that began 40 minutes prior to arrival period. The pain is intermittent, but mostly present for the last 20 minutes period. He took aspirin at home along with sublingual nitroglycerin period. The nitroglycerin helped for about 15 minutes before the pain returned period. The patient has a significant medical history that includes hypertension, hypercholesterolemia, and known coronary artery disease with prior cardiac catheterization 5 years ago, period. Insert TEC chest pain checklist. Okay, right here, I'm just going to go through by pressing the buttons to go cycle through these different elements. And so I can show you how to do this real quick. Yes. 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 Okay, so I went and I did my yeses, and then after that there's a check box. So I just hit the check box, and that took away all the brackets. Insert TEC adult exam. All right, I'm going to do the same thing. I'm going to cycle through using the little forward and backward buttons. But I'm going to tell you right now, since it's going to be the 2023, I'm not going to bother with a psych exam. I'm definitely not doing rectal or GU. I'm not going to do ENT or eye exam. And I'm also not doing a head. I'm going to leave it like that. And since this patient doesn't really have too much, the only thing is going to be warm and dry. Maybe some slight diaphoresis. So I'm just going to click here, go to the next one. Slight diaphoresis. Okay, so now my physical exam is in. Insert TEC MDM template. All right, so here's the 2023 global template. I'm also going to use a MDM that we've got for chest pain, or differential diagnosis. So insert TEC chest pain diagnosis. insert TEC chest pain DDX. Okay, again, this puts in a large amount of items, and I'm going to quickly cycle through by using the forward and back and take out the ones that I don't think are going to be likely. So for example, ACS, yes. Myocardial infarction, yes. Aneurysm, I don't think so. I'm going to take that one out. Aortic stenosis, no. Atypical chest pain, maybe. Chest wall pain, maybe. Cholecystitis, no. Costochondritis or cholelithiasis, no. Costochondritis, no. And I'm just hitting the delete key as I go through this. Dissection, maybe. Well, this does sound more coronary disease, so I'm going to consider it, but I don't think it's likely. I'm not going to work it up. Dissection's out. Esophageal rupture, also out. Myocarditis, perhaps. Pancreatitis, nope. Pericarditis, maybe. Doesn't sound like pneumonia for me. Definitely doesn't sound like pneumothorax. And possible pulmonary embolism, but again, I'm going to consider it, but I'm not going to work it up because I don't think it's likely. So I'm going to do the same thing. So these are things that I considered, but I'm not going to work up. So it's not going to be any of these because we're going to consider them right now. Aneurysm, possibly, but again, I'm not going to work that up just yet. Aortic stenosis, possibly, but not going to work it up. Atypical chest pain, we're going to evaluate. Chest wall pain, we'll evaluate. I don't think it's cholecystitis, not costochondritis. Again, dissection I'm going to consider, but I don't think it's likely. Esophageal rupture, I'm going to consider, but don't think it's likely. I'm going to work up and I'm going to leave in pulmonary embolism, again, because I'm going to consider it, although I don't think it's likely. All right, so I'm going to come to the chronic conditions section of the chart. Chronic conditions that are unstable include hypertension and potentially coronary artery disease, period. So comorbid conditions impacting evaluation and treatment. Hypertension makes the workup and treatment more complicated due to increased risk of cardiovascular complications, period. All right, EKG. The time of EKG completion was 1440, period. The EKG was interpreted by me, period. Rhythm is normal sinus with a rate of 82, period. QRS duration is normal, period. Axis is deviated to the left, period. Intervals are normal, period. ST segment and T waves show nonspecific ST T wave changes with some ST segment depression in V1 through V3, period. Portable chest x-ray was ordered and, per my interpretation, did not show any significant acute findings other than mild cardiomegaly and a tortuous aorta, period. A contrast CT of the chest was considered but not ordered due to the low risk of thoracic aorta dissection and or pulmonary embolism after a detailed HPI was obtained, period. CBC, CMP, and troponin I were ordered, period. The CBC results were unremarkable, period. CMP was unremarkable with the exception of a low potassium of 3.1, period. Initial troponin I was negative, period. Let's go over the independent historian. The patient's last admission discharge summary was reviewed, period. He had a prior chest pain admission 5 years ago that included a cardiac catheterization with angioplasty and stent placement, period. The The patient was placed on cardiac monitors and pulse oximetry, period. An IV was established, period. The patient was given nitroglycerin paste, period. Aspirin, and the emergency department was deferred because the patient took aspirin earlier in the day, period. Lovenox subcutaneous was administered, period. Oral beta blockers were given, period. Heart score was 7, parentheses, high risk, close parentheses, period. The patient did have improvement in his chest pain while in the emergency department, period. EKG findings are mentioned above, period. The patient's PERC score was negative, so no additional workup for pulmonary embolism was deemed necessary, period. The patient had classic symptoms of acute coronary syndrome and did not exhibit symptoms to suggest thoracic aortic dissection, period. Skip the social determinants of health, are not applicable to this one. Due to my current working diagnosis of unstable angina, the patient will require hospitalization, period. I spoke with the cardiologist on call, Dr. Miller, and discussed the patient's presentation, period. Dr. Miller agrees with the need for admission and cardiac catheterization, period. I also spoke with the hospitalist, Dr. Patel, who will write initial admission orders, period. The patient will need additional cardiac interventions, period. Number 1, acute coronary syndrome, unstable angina. Number 1, acute coronary syndrome, unstable angina. New line. Number 2, unstable hypertension. New line. Number 3, hypercholesterolemia. Admit to hospital for continued antiplatelet therapy and planned cardiac catheterization, period. Okay, so that is a very robust chart that will work for the MDM. It's also a pretty solid chart for medical legal reasons. The only other thing I'm going to do to make sure I've got all these brackets on there, I'm going to hit the little checkbox button, and it'll remove all the brackets so it looks clean and pretty and doesn't look like a templated type chart. So again, this took a little bit longer because of the discussion going back and forth, and it took a little longer because I didn't press the microphone button on one spot and had to redo it. But hopefully that shows you could build a very complicated chart fairly quickly if you use these AutoText templates.